Hello guys, we are going to have a chat in this session about paediatric medical emergencies, just a couple of them actually. We're not going to cover tons and tons, specifically relating to the changes in the current CPGs from 2017. Some of the stuff we're going to talk about. So the revised changes to the 2017 CPGs on stridor and glycemic emergencies in particular, paediatric respiratory emergencies and paediatric glycemic emergencies, because there has been changes in how we treat these individuals. So we're not going to go into heavy anatomy and physiology because we have already done that at our basic levels, but we will just revisit one or two little bits. Upper airway obstructions can cause issues obviously with the likes of stridor. So what is stridor? Stridor is something which affects the upper airway. And when we're talking about medical issues, these are the things that will cause inflammation. Croup, epiglottitis, an inflammation of the epiglottis, the likes of anaphylaxis. Any of these things will cause upper airway inflammation. Let's have a look. Cause edema. So lower airway obstructions will be foreign body airway obstructions if they go down quite low. Asthma, which are issues with the lower airways, and the likes of bronchiolitis or inflammation of the bronchioles. Respiratory emergencies. So kiddies' airways themselves are extremely small. They're funnel shaped and they can cause nasty issues because anything that's particularly small can block them. They're funnel shaped. Yeah. Kiddies themselves, they're predisposed to respiratory infections, viral, bacterial or fungal infections, the likes of oral thrush. They don't have a huge database of white cells because they haven't been exposed to the pathogens that live in this world that we get exposed to. It takes a number of years for us to build up a database of antibodies to fight these infections. So they're predisposed to snotty noses, sore throats, ear infections. A lot of them will manifest as inflammation of the upper airway. And it's typical when they're cutting teeth in particular from the ages of a year and a half up to about 3 that they get repeated sore throats. Any kind of inflammation of the upper airway of a child can cause huge issues. So themselves, how do we get rid of or how do we take care of, and we've seen in some of the other sessions, how do we take care of the likes of pathogens or bacteria that are not supposed to be there? So if we have a look, that everything is actually made of cells, as we know. So here's a blood vessel made of cells, nice and tight. We have a bit of infection. So we've got infection in the area. We have some pathogens which are, causing inflammation, causing a problem. We need to get white cells on scene to actually get rid of this. How do we do it? So this particular blood vessel here can end up looking something like this fella here. Why? Because the blood that's in this big dilated blood vessel now, this inflammation will facilitate white cells migrating into the environment where the infection is. Extravasation and neutrophils, we've actually got a nice little video on one of the other sessions. But this inflammation itself will cause and can cause huge problems for children. So small kiddies can have issues with, as we mentioned, the airway is kind of funnel shaped. And if we get a large amount of inflammation here, a large amount of inflammation here, and all of a sudden we've got an extremely narrow airway, and we're going to have extreme difficulty with shifting air in and out of this space itself. Okay, so this can be problematic. So, children are predisposed to respiratory infections. It can present as stridor if we get a partial upper airway obstruction. And the inflammation of those blood vessels there, although it's really small, in young children this can represent anything up to a 50% loss of cross-sectional area to shift air in, and it's particularly problematic. Viral infections cause inflammation, as do bacterial. Narrowing of the upper airway, this is our croup. Typically your kind of autumn stuff from kind of August onwards to kind of December, January, you can see this. Certain years it comes along a little earlier, like this year there was quite a bit of it in the late summer. Late autumn, early winter, seal-like cough can cause stridor with a huge temperature, usually worse at night. Normally kicks off pretty bad after midnight, between midnight and about 4 or 5 a.m. Can cause inflammation of the vocal cords. So 1 millimeter of inflammation or edema may lead to 50% reduction of space in the glottic opening and can lead to respiratory failure very quickly. We need to be mindful that children compensate for far greater lengths of time than adults do. Their metabolic rates far quicker, their heart rates far quicker, but they can compensate longer. And what looks to us like, a child just kind of struggling a little bit, if that was you or I, we'd be in big trouble. So, they can actually be pre-respiratory failure, and people don't pick it up. So I know we have some sessions on the likes of the Paediatric Assessment Triangle, the PAT. You need to really have a good look at that. So here's a video talking about croup. And there's a typical kind of really high kind of strider there. Okay. Here's another child. And that child is struggling to shift air through them vocal cords because of inflammation. And again, to us, to lay people, that's they just have a bit of an infection or a bit. Particularly at night, that can manifest and cause major problems with trying to shift air. They can be very, very problematic. So inflammation of the epiglottis is epiglottitis. It's not overly common, but it's something that we do talk about. Drooling as a child cannot swallow, so just a permanent drool coming down out of their mouth. It's a life-threatening condition. Major swelling of the upper airway. Again, if they can't even swallow down in through their esophagus, that whole upper airway is pretty swollen. May infect the trachea, leading to infective tracheitis, which is something that's a serious threat to life. Upper airway, which may present with stridor. And again, stridor in either of those two children there needs to be seriously investigated. They look washy, they sound lousy, they need to be looked at. Here's the actual paediatric stridor CPG itself. It's a pretty straight flow. There's a number of information boxes here which we'll have a look at. There's the old one, here's the new one. There's a lot more information boxes on this particular one here. Okay, so here it is at the top. Consider FPAO if we have a stridor, for sure. And that stridor can be from something really small, even a bead in the upper airway. Maintain, assess airway oxygen therapy. Consider humidified oxygen. Yep. So again, we're used to humidified oxygen. This is nothing really new. Some sterile water in the likes of your neb mask, and run it at 6 to 8 litres a minute. ECG and SpO2 monitoring for anybody with a stridor, any child. We need to be looking at peripheral saturations. Remember, children will normally sat pretty high. If they look washy and their SATs are depressed and they're symptomatic, then they really need to be really thinking about ALS with stridor in paediatrics. Consider humidified oxygen. It's non-core, but again, it's something that we need to know about. So, croup or epiglottitis suspected, no or yes? Signs of croup are significantly marked on this particular CPG, and it's something you need to be mindful of. So have a good look at them yourself. Hypoxia cyanosis, marked respiratory distress. Stridor. If I hear stridor in a young child, my ears are all wide open, and I'm really thinking about getting them to definitive care. Irritability or lethargy, marked increased respiratory rate. If persistent, treat as a croup. If you're called in the morning and it's been going on all night, the child may be a little bit kind of better now, but you'll know that they can be very, very tired. If they've been awake all night and struggling to breathe, they've burned a lot of energy. Be mindful of checking their sugars. Now, the change in it here, nebulized adrenaline may be repeated after 30 minutes as needed. So we're talking about nebulizing epinephrine or adrenaline now. Normally the dose as per your CPG is normally 5 milligrams, so it's 5 1 milligram doses into your neb mask and run it at 6 to 8 litres a minute. This should have significantly improve the child pretty quickly. We also talked about dexamethasone, which again is covered in your pharmacology as a second line steroid administered within the past 17 hours and not to exceed 600 mics. Again, have a look at the pharmacology of this. dexamethasone and epinephrine. Nebulized epinephrine is the one thing for croup that will really sort stuff out. Any kind of stridor in a small child, think of epinephrine. Okay, they're the real big changes. Here they are here. Adrenaline less than a year, 2.5 milligrams neb. Over a year, 5 milligrams. So the age changes a year. So any child over a year gets 5 milligrams of epinephrine. Under a year gets 2.5. Dexamethasone is 300 mics per kilo, PO, or 300 mics per kilo intramuscular. So we have a couple of different routes there. Check the temperature. If it's greater than 38.5 and septic, you need to be also thinking, I suppose, nowadays of the likes of COVID. 2021 CPG changes. The information box signs of croup have been added, and we've discussed that already. Dexamethasone is introduced for paramedic administration, and again, being a steroid, it will help the child significantly in an hour or so. Frontline treatment for the big croup would be the epinephrine, or the adrenaline, should I say. Nebulized adrenaline added for the paramedic skill set. It's been with the APs for a number of years. So let's have a listen to these breath sounds. Lower airway problems caused by asthma. So asthma being a spasm of the small airways. It causes a whistling as air passes through the small passages. Almost like pursing your lips to whistle. When you get to a particular amplitude, you'll hear the whistle. And the very same with the small airways deep in the lungs. It's chronic. It's relieved with a blue inhaler, which is normally Ventolin. Treatment as per the CPG, there's no change. So salbutamol, less than 5 is a 2.5 milligram neb, and greater than 5 is a 5 milligram neb. Again, this is pretty standard stuff. We're just touching on it. This is as per your original CPGs. So asthma pediatric, again, having a look at it, running down, you have your salbutamol running front line, and then you have your ipratropium bromide kicking in there as well if there's no improvement after your initial salbutamol dose. Consider peak expiratory flow. Consider advanced paramedic if you're seeing, be mindful of tiredness in an asthmatic patient, and again, your sample history is the big thing to see how long this is going on. Signs of in children, signs of respiratory distress or respiratory failure. You have the likes of your flared nostrils, your tracheal tug, your substernal subcostal attractions, and again, we do pediatric advanced life support. We do emergency pediatric care. If any of you guys care to come and sit the course with us, it's pretty good. Okay, again, we're just running down through it. Your initial salbutamol dose will be augmented if there's no improvement, your ipratropium bromide. And again, if you have advanced paramedics, you can give the likes of hydrocortisone. Okay, glycemic emergencies of pediatrics, there's a change on this. And the change on it is, you're having a look at your blood glucose levels. Less than 4 millimoles. Are they conscious? Yes. Glucose gel. If they're conscious, no. Glucose 10 IV. So you're looking at an advanced paramedic for your unresponsive. Your AVP or U. So P or U, you're looking for AP. And you guys as paras can manage the rest. Blood glucose levels 11 to 20. So the levels are elevated. If they're over 20, we're looking at requesting ALS. We're running on down to the likes of, you're thinking about your advanced paramedic giving some IV fluids. That's fine. What can you guys do? You guys can measure for ketones. So what are ketones? We'll have a look at this now. Let's have a look. So diabetes is a condition caused by a lack of or insufficiency of insulin. Insulin being the hormone that allows the cell membrane to open up to receive sugars. Sugars do not get into the cells without insulin. So insulin acts like a key to open the door into your cells, let the sugars in. In diabetes, the pancreas makes too little insulin to enable all the sugar in your blood to get into your muscle and other cells to help produce energy. Sugar can't get into the cells to be used, it builds up in the blood, which gives us hyperglycemia. Therefore, diabetes is characterized by high blood sugars all the time, and it is. Type 1 diabetes, which is normally an autoimmune condition, causes your cells to kill off your insulin producing cells. So your body no longer makes insulin. This normally happens to young children anywhere from the age of 1 up. It can also happen to your type 2 diabetics who basically have lifestyle or they have issues with the likes of uptaking insulin. If they do not change diets or lifestyles, they can become type 1 diabetics as well. So your type 2 diabetes, your body makes insulin, but it isn't used properly by the body. There's not enough insulin to meet your body's demands, resulting in insufficiency. Either we end up with high blood sugar levels. Children with high blood sugar levels, it's pretty bad. Ketones themselves are what we're looking for. If we have ketones are bad. They're bad for business. They destroy tissue. Patients with known diabetes consult with parents. Insulin pumps are now very common and we need to be mindful. Insulin pumps can titrate tiny amounts of insulin and make blood sugar regulation very, very tight. If there's issues with pumps, we need to be mindful of maybe switching a pump off. If sugar levels are low, we need to be mindful of turning off a pump. If we're not sure, ask parents. Contact advanced life support if they're available. Non-diabetic pediatric hypoglycemic patients are not treated with glucagon as per the CPG. So if they're hypoglycemic and they have low sugars and they are not diabetic patients, then they do not get glucagon. So hypoglycemia can be caused by plenty of other things, and hypoglycemia can also induce seizures. So we need to be mindful of this. Hypoglycemia symptoms. There's some nice little cartoony things here you can have a look at. Again, glycemic emergency patients, having a look, pediatric, having a look through the actual algorithm itself. Abnormal blood glucose levels, so hypoglycemic, we consider glucose gel, or we can go with glucagon if the patient is a known diabetic. 11 to 20 we're not going to do anything with, but if they're over 20 we're going to ask for ALS. And then under here it has consider ketone measurement. The important thing about this, there's a lot of joule, there's a lot of meters, joule meters, so you'll have a meter for measuring blood sugar levels. So a lot of these machines also measure ketones, which is really, really handy. So consider ketone measurement. Ketones are a chemical that your liver produces to break down fats. So when we're looking for a source of energy, if we have an issue with the likes of a child, we'll say, who is they're not getting sugar into their cells, the body's going to release ketones to start breaking fat down. You produce them when you don't have enough insulin in your body to turn sugar into energy. Ketones are really, really bad. They're very damaging for children. We need to know if ketones are there, because if ketones are there, the child needs to go to the hospital. You need another source, so your body uses fat instead. Your liver turns this fat into ketones, a type of acid, and sends them into your bloodstream. High levels of ketones in your bloodstream or urine can mean you're at risk of developing diabetic ketoacidosis or DKA, and this can be a serious threat to life. So DKA, diabetic ketoacidosis, is pretty bad for kiddies. Measuring ketones and the presence of any ketones is bad. So it's really important if we have a ketone meter to measure. DKA is common in people who have not yet been diagnosed with type 1 diabetes, especially kiddies. So it may be the first time, it may be that their body is literally just failing to produce insulin right now, and all of a sudden their sugar levels are rising. And because their sugar levels are rising, they're going to become very thirsty, and they're going to urinate a lot as they try to get rid of excess sugars. If you can envisage the likes of golden syrup circulating around your system, your body's going to want to get rid of that and dump it. So the patient will become extremely thirsty, and they'll be display polyuria and urinate quite a bit. They will also, over a day or two, start to lose significant amounts of weight. Remember, they don't have any fuel to live, so they're actually starving from the inside out. They don't have fuel. They can eat all they want, but the fuel is not getting into the cells, so they're going to start to lose weight as the body metabolizes fat stores. Over 20% of children diagnosed with diabetes are already in diabetic ketoacidosis. So on their first presentation, 1 in 5 of them will already be DKA, which is pretty bad. If blood glucose levels are over 20 and they have signs of dehydration, the same glucometer, just different strips. We need to be mindful. Not all services will carry appropriate strips. You may not be able to measure ketones, but if you have a meter that does, a glucometer that does ketones as well, we can measure both. Signs and symptoms of diabetic ketoacidosis. So the polyuria, they're urinating a lot, they're really thirsty, and they're really hungry. Why? Because fuel is not getting into the cells, which means what's going around is becoming thick and sludgy. So the body is going to be very thirsty to try and get rid of them, and yet the patient is still hungry. Weight loss, because the patient is basically consuming its own muscle and any kind of fat stores they have to survive. Flu-like symptoms, basically they're going to have an altered level of consciousness and they're going to feel lousy. So these 5 things are pretty common. Summary. So respiratory emergencies, upper and lower airway obstruction, causes and treatments we've had a bit of a chat about. Literally we just reinforced the asthma. Your initial dose will be your salbutamol, followed by your ipratropium bromide if it's unresponsive to same. Your upper airway, again, your upper airway stuff will be your Stridor, which now will be treatable with your adrenaline. So over 1 is 5 milligrams, less than 1 is 2.5 milligrams. And again, this is going to be reflected in the pharmacology education that you get online. There is a little bit of practical to do with this, which we'll do on the day when you're in here in a training centre, and I hope you enjoy.